Hi there, 3254, Dr. Ang here. I am coming to cover the content related to medical legal liability and patient consent. I'm going to go through and give you a little bit of a video PowerPoint that you can take and highlight. This can be your guide as you study the content related to this class, but it specifically is medical legal liability, and then towards the end we're going to hit patient consent. I'll try to highlight those aspects that are going to be more critical and require a little bit more of your attention as we go. So if you want to jot down notes with that. And then at the end, if you have any questions or concerns that arise during this, then you can let me know. But please do look at Harvey. There's several resources, several examples that you can use, obviously for sake of this course, but you can also use them for your personal use or your family, whoever could benefit from those. But there are certain documents that are there that are easily accessible. So I do hope that you'll spend time looking through Harvey at those, and we'll be referencing those throughout the PowerPoint here. So class learning outcomes, we are going to hopefully understand medical and legal theories. We're going to understand the concepts of medical liability. What is informed consent? It's something that we hear a lot of, but what actually, when we peel back the onion, what actually is informed consent? And more importantly, what is our role as a nurse when it comes to informed consent? What is indemnification, and what does that mean, and how does that apply to us as a nurse? Can a nurse get and obtain an informed consent? Is that part of our role, or what? As I've mentioned, what actually is the role of the nurse in informed consent? And a lot of times those lines are blurred, especially if it's in a rather acute situation when there's a sense of urgency. Sometimes that can get blurred. So we need a clear definition, because if we step over that, then there's not protection of our nursing license in that moment. So also self-determination and advanced planning. Again, this is what I mentioned. This is going to not only be useful for the course, but also think of your family dynamics and how these documents might apply and which ones you'd want to implement as we go as well. And you're also going to be hopefully better educated and have more information in your tool belt that you can access and resources that you can present to patients in the future. So specifically, advanced directives, living will, what's a healthcare proxy? Guardianship representatives, and then POLST, P-O-L-S-T. That is another one that typically students are less familiar with, but we're going to dive into that one as well, equally as important. Medical liability, what's another name for that that's probably a more common street term, is malpractice, medical malpractice. It's regulated by the state, and in civil claims is where we address malpractice issues and claims. Occurs if the healthcare provider causes injury or death through a negligent act or an omission. So whether it's something that we failed to do as a nurse, or whether it is something that it can be intentional or non-intentional as well. But if it's something that a reasonable or prudent nurse would have done in the same situation, or is it something that you were outlining that, and as well as there are certain things that are intentional, things that could be deemed more of an accident nature. So being able to differentiate those is also very specific to this topic. To recover damages. So when there is a damage done, how is their compensation? How is it justified? How is that patient, or if it's the loss of a patient, that family, how are they compensated for their loss? So the patient must establish, in order for a medical malpractice case to be valid or viable, it needs to have the provider owed a duty to the patient. So when we're referencing nursing, this can be applied in different aspects, whether it's it can be a nurse practitioner, it can be a provider, it can be a medical doctor, physical therapist, and in our case, nursing. So you can generalize this to other disciplines as well. But the provider must have had duty owed to a patient. So if a patient comes in and I'm assigned to this patient, I am there to give a certain standard of care. And once I am assigned, this is so-and-so, and I'll be your nurse today. I am now have a duty owed to that patient. There is a standard of care, and the provider violated that standard of care. So for nursing, we have a standard of care. There's a level of care that is owed to any citizen within our state that comes in to access that health care. And if we fail to meet that standard of care, then that's another check box that's going to tilt the scale in a medical malpractice claim. The injury is compensable. So certain things, it was a wrong, and it was maybe possibly a mistake. It was an accident. It should not have occurred, but there weren't necessarily damages done that are preventing someone from working, or they haven't left the patient in pain, or long-term effects did not occur from this. So the injury must be compensable in providing a claim that your life has been somewhat altered based upon this offense. The violation of the standard of care caused the harm suffered by the patient. So if I leave a bedside rail down and my patient does not fall, but they could have fallen, and I'm written up because maybe someone came in and the patient was starting to slip out of the bed or something of that nature. I'm written up because the standard of care is I'm going to provide a safe environment. And if I leave a bedside rail down, that is opening wide up for an accident and an injury to occur. Now, if this same patient is discharged 2 days later and they slip and fall on the ice when they're leaving the hospital and leaving the wheelchair to get into the car, and they slip and fall and now they've suffered an injury, they cannot come later and say, because I broke my hip, it's linked back to Nurse Sally left my bedside rail down, and I know that was below the standard of care, and she was written up, so I'm going to directly link that. That is not the case. And that seems as though that would be logical and common sense. However, we watch this very closely because there are some patients, unfortunately, are just looking for pitfalls for someone to fall in that they could flip into a claim. So we just want to be careful and be mindful of that. But just to refresh, in order for a malpractice claim or nurse negligence claim to be filed and to be viable, there must first be provider owes, there's a duty owed to that patient. So you're directly assigned to that patient for that day or for that time. There's a standard of care. So for nursing, there's a standard of care for what care I will deliver to that patient. And then the injury is compensable. There is damage done that needs to be compensated for. And then the violation that brought below the standard of care is in direct correlation to the injury that was suffered by that patient. Who is considered a provider? As obviously the first one that we know of would be a nurse. Also, it's not just the nurse. We're going to get a little bit bigger. It's hospitals. It's any provider, healthcare provider. It can be a nurse practitioner. It can be a medical doctor. It can be a PA. It can be a nurse. It can be a physical therapist. Independent contractors can also come into play. There can be nurses that are traveling nurses. There can be cases where we have home health nurses that are on contract, even working for a hospital, but we sometimes have to be very strategic in how we piece together the collaborative care. So when you think of who is considered a provider, I want you to think of all the individuals, but then also collectively when we consider hospitals, and knowing that for-profit hospitals are a corporation. These are all members of the topic of underneath the heading of provider. Independent liability. Independent contractors can be doctors or nurses again. Some doctors will work for the hospital, some will not, and they just will provide their services there for the hospital. I am going to plug in before I lose you guys here. Sorry about that. There's also borrowed agents if we're hiring. We're short-staffed, especially during COVID, when we're trying to pull in. We have shortages. We have our regular staff. Some are being quarantined, some are out, and we're trying to fill in and plug those gaps because our census is going up, but unfortunately our workforce was dropping. So we were having to plug those gaps with some borrowed agents, which would be contract nurses, traveling nurses, that type of nature. Nurses that work through agencies and they place as the need is there. And then the agent, which is an employee of a corporation. These, you don't have to worry about all these titles. I just want you to see that, just to step back and kind of think. There's a lot of nuts and bolts that go into this machine of healthcare, and looking at that and how we're all players in this game. And when there is an offense or a claim that's made, there are a lot of individuals that fall into this team that are brought into collectively, and that come underneath a overarching corporation, the hospital, and there can be different entities within that. And you want to be educated on that, but you don't need to be an expert in these topics here. So again, the next slide just kind of goes back into borrowed servants, dual servants. Again, this can also be if you have a contract physician that comes in and it's a surgeon. So let's say a specific thoracic surgeon that a hospital needs, they need to provide that service. They can contract in a surgeon, but when they come into the operating room, they may be working hand in hand with nurses that are employees of that hospital. They do not work for that physician. They work for that hospital. So we can get into some cases where a physician may ask the nurse to do something that is in direct violation of the hospital policy. So that can get into some gray areas, and we can address that further as we go. So nurse is an employee, again, of the hospital. If you go to work for, if you're in the Tulsa area in one of the 3 big hospitals that we have here, you're an employee. You're not under contract. You're an employee of that hospital. And as a nurse, you will be an agent representative of your employer, and therefore convey potential liability to your employer. So when you are an employee for a hospital and then for that corporation, you are liable for any offense that occurs. But also, you also have that protection, and you're underneath that umbrella. Whereas if you're an individual contract nurse or you're from an agency, you're not underneath that umbrella. So that's a positive of working for one of the big institutions, and also something that if you're interviewing for a job, that you ask, what kind of coverage, how does this look if there was ever a claim made by a patient? How does that look? What steps do you take to protect nurses? Because we are definitely in a litigation heavy society where many people are looking for people to blame, and they want to get instant gratification for things that they feel that can benefit them. And many times it's valid, and then sometimes it's not. So we want to know as nurses, what does risk management look like? What steps do you take to protect the nurses that work for your institution? Because if you're doing all you can, and we hope that you are, then you're going to want to know that the hospital has your back. And as long as you don't step out from underneath that umbrella of the standard of care for nursing and the policies within that hospital, then you will be covered for legal purposes, for the legal coverage underneath that hospital or that corporation. So to recover damages, the provider, again, you're going to see a common theme with this one in it. We went through this just a few slides ago. The provider owed a duty to the patient. Okay, this is in order to recover damages. These all have to be met. There's a standard of care for that provider, and that was a direct violation. The injury, again, requires compensation, and the violation was a direct violation of the standard of care. Those four all have to be there in order for there to recover damages for that. Nursing standard of care. What is our standard of care? And when we're in class, I like to pull that up, so I have the references for you in Harvey. But ethical and legal duty of a professional to exercise the level of care, diligence, and skill prescribed in the code of practice for our profession, or as in other professionals in the same discipline would do in a similar situation. So what would a reasonable and prudent nurse have done in a similar situation? That's what you're going to be compared to. If there's a claim made of something that I did, then when it comes into litigation, they're going to look, what would a reasonable, prudent nurse have done if they were in the same situation? And that's when we'll pull in fact witnesses, we'll pull in legal experts, possibly even a charge nurse for that area. What did this look like? What did the census look like? What was the environment? And this is what this nurse did, and we're going to mirror that up against what would 2 or 3 other nurses have done in a similar situation. And maybe they were short-staffed and there were increased census and there were a lot of things going on at the time. There were 2 codes going on. And given in that scenario, maybe an offense is not deemed as detrimental if given the scenario, and maybe a charge nurse would be able to speak to that. Yes, I'm on that floor. I know what the environment is on that floor. I know how it was. This is the census. And actually, this was not negligent. This was someone doing the very best they could given the situation at that time. So at least the offense wouldn't be, although it may require compensation, it may not be as detrimental to that nurse given the situation. However, on the contrary to that, if we look and we say, this is what a reasonable, prudent nurse would have done in the same situation. However, this nurse that has the claim against them was way over here. They were completely out of the standard of care. That is not the policy of the institution. There is not any foreseen reason why the nurse operated the way that they did, and they are out of that standard of care. So, nursing standard of care, you can go on the Oklahoma Board of Nursing website. We can pull up what the nurse's standard of care is. And I want to encourage you to actually look at this and read this and study this, because what's interesting, we are now in the world of Google and the internet. We have very, very savvy families and clients and patients that have medical knowledge at their fingertips, and they also have, guess what, our standard of care. And if there's a patient, and hopefully there's not, but there are these people that are seeking to try to find some compensation for a healthcare error. So in that realm, they can study the standard of care and try to find something where you're falling short. And I don't say that to scare you, but just to let you know that patients are savvy and they are educated and they have this information at their fingertips, and so do we. So we need to make sure of all things, if this is our profession, that we first and foremost, we are familiar with what the standard of care. If we're not familiar, how do we know whether or not we are operating within that standard of care? So again, the next, I just alluded to this, Oklahoma Board of Nursing website. Pull that up. You can see on the far left, you can see our standard of care. Nurse Practice Act, you'll see that listed. Corporate liability to ensure the patient's safety and well-being. That is what we owe if we're in the state of Oklahoma, wherever we are. A hospital may be liable if it fails to uphold proper standard of care, which is owed to the patient. Any patient that walks through the door of a healthcare institution is owed a certain level standard of care, and that is our job. So it's to ensure the patient's safety and well-being by the healthcare team functioning within the standard of care. Creates a Delegable duty, which the hospital owes to the patient. Corporate liability, duty to but not limited to provide satisfactory patient care, and it's the job and the obligation of the corporation or the institution, the facility, to have adequate staff. It seems that there's always a buzz that we were short-staffed, but that is following out, that is not providing the standard of care, and you're setting your nurses up to not be successful if you have them functioning in that environment. And that's something that before you take a job as a nurse, you're going to want to look at as well. What do they do to, is it rare that they're short-staffed, or is it pretty much common? Because we don't want to work in an environment where we know we're being set up for that. That's going to be very difficult if you know you're always short-staffed. And we know that that is a duty owed to patients that come and seek health care within that institution. Safeguard patient valuables, that's another duty that's owed within a institution. Provide a safe environment for not only for patients, but also for employees. We want to, it's equally as important that not only is the hospital or the institution there for those seeking health care, it's also there to protect those employees that work for that institution. And then provide favorable treatment. So equality, justice for all of these legal terms and buzzwords come into this. This is corporate liability. These corporations and these facilities and institutions owe this to the citizens and to the patients, future patients that are coming in to seek that health care. Okay, you can look on the next slide is vicarious liability, a legal doctrine holding one's personal liability, responsible for the actions of another when engaged in some form of joint or collective activity. So this can be a example in the case of an employee. The employee is, they're going to be answerable for torts, or torts is anything that can land you in court. Remember, any wrongful doing committed by employees. So in other words, an employer is going to be held accountable for something that's done by an employee. So the only time that they won't be is if that employee stepped out from underneath that umbrella of the standard of care and the policies for that institution. But if you are providing care within the standard of care for our profession and within the policies and procedures of that institution, then the agent or the institution will also be liable. So you would be named with the institution and not alone. So here's another slide that kind of goes into that. Again, burden benefit analysis. I want you to look into this because some things can be deemed, basically you want to know whether the benefit outweighs the risk. And if you look at the risk, you would think, why, for example, of a medication, why would you give that patient that dose of a pain medication? And that would be detrimental to that patient. And if you look at that, that's true. But if you look at burden benefit and the risk versus the reward of that, then that's maybe justifiable in the case of maybe a hospice patient. So is the benefit going to outweigh the risk? All these are aspects that it's looking at the whole picture and not just this nurse administered too high, unsafe, deadly dose of a pain medication. Okay, that may be true that was administered, but then when we back it up, we see that was a team and the physician ordered that. We back it up, we see that there was advanced directives and a proxy in place, and we continue to back it up and we see, okay, this patient has been suffering with a particular diagnosis, and all these steps lead up to why that step was taken. So you'll see that the whole story will come to play, and it won't just be focused on that one claim that someone might have of if you're trying to present liability and link a claim to a specific nurse or a specific deed. We're going to look at the whole picture, so that should be comforting to you in that case. Let's see. Okay, employees have rights and responsibilities. Consider negligent hiring, retention of a negligent person. So this is the case when if there's a medication error, then you would write an incident report, maybe go to a class to understand, make sure that you're competent on that, and then you would be, returned to the floor and continue working. If it continues to happen and there's a pattern, and then an institution says we're really short-staffed, that's why we're going to just have to keep him or her on, that can be liable and negligent on the case of that employer. So what steps did you take when there was an offense? And then if it continued to occur, what steps did you take to release that individual so that further harm did not occur? Tort law, again, anything that's going to land you in court. Medical malpractice, a specific subset or a tort law that deals with professional negligence. Medical malpractice is defined as an act or omission by a healthcare provider during treatment of a patient that deviates from the accepted norms and practice or standard of care. Just kind of a repeat of that. Okay, this is a case that res ipsa loquitur is a term that basically means the item speaks for itself. So for a surgeon, if you're giving your deposition and trying to claim that this is not your fault, it was not you that did a certain offense, and then they come up and show the evidence that's on the next slide, which is slide 21, and you see the scissor on the x-ray that the surgeon left inside the patient and then closed the patient up. It further came to the patient had an infection, had to come in, required another surgery, led to weeks off of work because of this ordeal. This is res ipsa loquitur of the item. Let the item speak for itself. And when you pull up the x-ray in a courtroom and you show this, it pretty well will shut down the claim. And yes, you can't really dispute this in this kind of case. Most common surgical malpractice claims are going to be wrong site, heaven forbid, wrong patient, infection, retained instruments such as a scissor, sponge, whatever the case may be, damage to organs and tissues or perforations during a procedure, and nerve damage. These are the most common torts or malpractice claims that you're going to see. Top 5 medication or medical errors. Misdiagnosis is unfortunately a big one. Medication error, wrong patient, wrong site surgeries that we just mentioned, anesthesia errors, and then childbirth errors are our top. That's probably our top 5 areas. So you want to focus, and I just let you know this to see where errors tend to occur, and it just helps us keep our radar up and be alert. Again, now specifically for nursing errors, it tends to be more, because we're not diagnosing, we're medication errors, patient falls, errors related to documentation, procedural errors, and then prioritization. So we don't need to be giving a bed bath or walking a child around the circle if we have a patient that is in severe pain, or a patient with a level 3 pressure ulcer. They have a pressure point and they're in agonizing pain, and it's further deteriorating, and we are doing something that is far less critical in that moment. So prioritization is also on there. So that's one that's less attention on that, but I do want you to know, because we all know as you come with a nurse, you're going to have a clipboard in your mind. Just think, a clipboard full of things that you need to prioritize, and you have this list running. It's in a mental image, but all these things that you need to do, And every time you log into Epic or whatever your thing, you see all this stuff to do, and you have to decide in your mind how you're going to prioritize that and be beneficial to all your patients. And if there is an offense, how you would justify how you chose to prioritize your time. Again, nursing negligence. A charge of negligence against a nurse can arise from almost any action or failure to act that results in patient injury. Most of the time it's unintentional. Unfortunately, sometimes we will have that nurse that will take medications and put them in his or her pocket instead of administering. That is not in any way an accident, and that is more premeditated, and that would fall under the line not as just a civil case of trying to negotiate nursing negligence. That would fall into a criminal case. Increased number of malpractice cases are for these areas. Delegation. If I delegate to a tech to change positioning and turn my patient every 2 hours, and then I get to the end of a 12-hour shift and find out they have a pressure sore that went from a 1 to a 3 just on my shift, and I say, hey, I delegated that. I delegated that to Johnny, and he said he would do it. I'm the nurse. This patient is assigned to me. So what is that? Duty. I have the duty to perform. If I delegate, I have to follow up. And if that's not done, that still is falling underneath my duty. Early discharge. Discharging a patient before they are ready to go, before they're educated, not finding out if they have their medications, if they have what they need when they get home. And a lot of times this is rushed because there is a push to get our patients out sooner and shorten those hospitalization stays. But early discharge without proper education and making sure they know what resources and what to look for. Make sure you call immediately and list those off. Making sure that is a smooth transition as best as possible because early discharge is creeping up from medical liability. The nursing shortage and hospital downsizing have contributed to greater workloads. And then advances in technology. Technology is ever changing, and I'm responsible. I can't say I didn't know. I wasn't trained on that. I have to seek out that knowledge. And you can say I'm not comfortable with something, but you still need to do it because you need to get comfortable. You need to get that confidence built up as a new nurse. However, if you say I am not competent on that, I have not seen that device used before, I do not feel comfortable hooking that up myself and following through with that. I need someone else that has experience with that because I am not competent is much different than I'm not comfortable. So if you see the difference with those, because technology is ever changing, and yes, you can't say that I'm not competent and just get out of all your work. Obviously, you would need to get in on that so that then you are competent next time. Increase autonomy and responsibility of hospital nurses. Nurses are doing more than they ever have before. Our roles are expanding. We're moving into advanced practice nursing, different aspects, and nurses are assuming more responsibility. So therefore, nursing liability cases and claims are on the rise as well. Just kind of mirroring that because we're doing more. So that kind of makes sense. And then more informed consumers, what I just mentioned. They're Googling, they're looking up stuff. They have access to the internet and they know what you're supposed to be doing, and they're probably watching and taking notes to see if you are or you're not. For me, I just think you have a good rapport and a good relationship with that patient and that family member. And if there's questions or if they have concerns that they feel like there's that, you want to empower them. You want to give them as much knowledge. You want to give them as much dignity and respect as they can. You pull out all of this. You want to make sure that they are informed in their decisions that they're making. All of these aspects, when that patient and that family feel empowered, they're less likely to fill in the blanks and for things to start snowballing in problems. So just take time to make sure you connect with them. Let's see, expanded legal definitions of liability. You can read through that one as well. Again, you cannot say in a court that I didn't know. That's not the case. That is never going to be an excuse that I didn't know or no one told me. You are responsible. You're a professional, and you're responsible to know that standard of care and to meet that. So consent. I'm sorry, I'm talking kind of fast, so you can pause this, but I just want to kind of give a little peel back the onion a little bit and let you know, but then highlight the things that I think are important for you to know, because I want you to use the rest of your time to access those documents on Harvey. And I also have a video on there that I want you to watch as well, related to end-of-life issues. Informed consent is a process treating healthcare provider disclosures appropriate information to a competent patient so that the patient may make a voluntary, not coerced, voluntary choice to accept or refuse treatment. Originates from patients' legal and ethical rights for self-directed care and decision-making. You're a healthcare provider. You have strong opinions about what you would do or not do if it was you, but it's not you. So we want to make sure we present all the information, and then we empower our patient and their family to make the decision that is best for them. Elements of full informed consent: the nature or the decision of the procedure, reasonable alternatives to the proposed intervention. Sometimes you'll get a surgeon or a provider that tends to like one procedure. They like to do one procedure. They want everybody, and it's not a one size fits all. Yes, this is one option, but what are my other options? And what would happen if I didn't do this? What would that look like as well? I want the whole picture. We give as much information as we can about the choices that they have, the relevant risks, benefits, and uncertainties related to each alternative. So we're going to get the pros and cons of each. Assessment of patient understanding, the acceptance of interventions by the patient. So we're going to give that information, and then it's very nice to have then the patient and family kind of regurgitate that back. So did they understand? And you want to give this in a language that they understand. You want to speak at a grade level that they understand. You don't need to try to impress at this stage. You want to talk where they're at. You don't need to talk down to someone, but just get a feel for how much information they know. And even if it's a healthcare worker, sometimes they don't want you to speak to them as healthcare workers. This is a mom, or this is a dad, this is a child. So speak to them where they can understand the procedures, the risks, and the benefits. Valid consent. Patients must be competent to make a decision at hand. Consent must be voluntary. If you could have a tort, you can have a claim against you if they feel that you have coerced them into something. Again, this is not us, so we give the information, we answer to the best of our ability, and then we leave the decision to the patient and the family. Is it ever acceptable not to have a full informed consent? Yes, it is. If you're incapacitated, dementia, if dementia has occurred, if it's an accident and you're rolling through the emergency and needing a life-saving procedure, in these cases, patient can waive the consent and action will be taken. If it's a life-threatening emergency, especially, competent patient designates a proxy to make decisions. So this is something that's important that we do sooner than later, because you never know when you're going to be in a situation where you want to have someone named that can make that in the event that you can't do it yourself. When is it appropriate to question a patient's ability to participate in decision making? There's essential elements. So possession of a set of values, preferences, and goals, ability to understand information relevant to the decision, ability to reason and deliberate, and then the ability to communicate one's choices. So if you can't have a full conversation with the patient, this may not be a patient that's going to be able to consent for themselves. Assessing capacity. This requires skill and a lot of times it's going to be a psychiatric consultation to be able to realize, are they in a position to be able to comprehend and communicate their wishes? There's another, again, to know the difference between capacity and competency. Then the role of the nurse, the key for informed consent, the duty to obtain a patient's consent for treatment rests with the patient's treating provider or physician. That is who is going to obtain the consent, not the nurse. Hospital nurses, surgical assistants, and referring physicians do not own this duty. That is not the duty. It's for the providing or the treating provider. And this cannot be delegated. So you can't have a physician that's in the office and then they call in to you and say, who's the nurse for room 220, Mr. Smith? Can you go in there and get an informed consent? I need that by the time I get there for the procedure. That can't be delegated. So as a nurse, you would know you would not take that and do that, because that's falling underneath our role as a nurse. So that would not be something that we would do. The duty is not eliminated, lessened, or spread by having the hospital nurse secure the patient's consent before surgery. That is not something that we can do to speed up the process in any way, because it belongs to who? The treating provider. Self-determination, back to the informed consent. The only role that a nurse has is witnessing their signature and their consent. So we witness that, and in the event that the treating physician leaves, we have the signature, and then a patient starts to question things, and you realize they do not even understand what just happened. And you realize that competency was not there. They did not comprehend what was just said to them, nor what they just consented to. The role of the nurse at that point would expand from they just witnessed this to now they're going to advocate for that patient, and you're going to call back that provider and say they still have questions and this is not a valid consent because they were not comprehending that informed consent. And that may get some providers irritated at you as a nurse, but it's more important that you advocate for that patient in that moment. Self-determination and advanced planning, advanced directives, living wills. These are all basically documents that you provide stating what your wishes are and who in your circle of life would you want to speak for you and have a voice for you if you did not have a voice for yourself. That's what these documents boil down to. DNR, do not resuscitate. This is one when you do not take further life-saving strategies. If you're in that moment, is a DNR. DNR is also important that you note that can go back and forth. Sometimes families and patients will change their feelings on this. So it's important that if you're working in a facility where you see this go back and forth every time, just because I took care of Mrs. Johnson last week and she was a DNR, I need to check to make sure that still is the case. So that would be very important that we keep track of that, because that's a very serious one. And then POLST is also an idea that was formulated for wishes for a patient, and it's something you sit down directly with your physician and you write out exactly what you want your final time to look like. And you can have people there with you that are in your circle as well, but this is your wishes made directly with your physician, and that will be carried out, and your physician knows this is exactly what they want, and these are the orders that are going to be in place because I have met with that patient. They were competent in that moment. They had the capacity to make those decisions, and we wrote out this plan of care, and they are going to make sure that plan of care is followed. So you can look in the next few slides, and it's just a little bit of what I talked about, but it's going to dive a little deeper. Oklahoma law regarding decision makers for incapacitated persons. This is surrogacy. You can have a surrogate that would speak on your behalf. Again, advanced directives. I have a video on there that you can clip on and see. This was about 45 minutes. There's a video that I want you to see again that's found on Harvey. It's talking about end of life And it takes a different twist, so don't be like offended by it at first, but just kind of feel for it as you're looking, and look at the interactions between the people that are sitting at the bedside in the final times, trying to figure out what should we be doing. And when they're trying to think, what would my loved one that's in the bed, that's facing this incredibly difficult situation, and they're trying to determine what that individual would have wanted, because conversations maybe didn't take place early on, and you want to avoid that, of trying to make a decision and trying to choose what someone else would have wanted. If you could have had that conversation and just rewind and had those conversations, then you could be better prepared in that moment. It's a terribly difficult moment. So the more prepared you are, the more competent and confident you're going to feel in standing up and advocating for your loved ones. So when you look at all of these, discuss with those in your family circle. How do you feel about advanced directives? Let's work on this. You can even go into, there's several that you can get online. You can pull them off of Harvey. You can print those. You get the signatures. You can bring that in and have that as a liable document. So it's not a huge process. It just takes some little bit uncomfortable conversations sometimes, but you'll sure be glad that you did it. So I wanted to make those available for you on Harvey. I'm here to support you in any way that I can. I've had some students as well as myself that have had to actually be in these uncomfortable moments, and I like to dive into that with students that feel comfortable. So reach out to me if I can be of any assistance with that. And if you need help accessing any of those documents or want to know the process of how you would roll that out, and that's just more of a side note, sidebar to just life in general. But as far as the case of prepping for exam 2, as well as what you're going to see on the final and then most likely on NCLEX, just know some of these that I have hit in this video. And if you take this, jot down notes as we've gone on some things that I've said with this, it'll help guide your studying for the legal aspects related to 3254. But any questions, any way I can help you, anything related to legal, please reach out. I would love to do so. Take care.